Malaria Burden, Program Target, and Epidemiological Determinants. Dr. M. Pradhan, ADPHO, VBD, BODE, State, NVBDCP Technical Guide.
This presentation will cover the following sections: Global and National Burden, Economic Impact of Malaria, Odisha, a Success Story, Strategy and Epidemiological Determinants, Shifting Transmission and Challenges, and Vulnerable Populations and Factors. Section 1, Global and National Burden. We will begin with the malaria burden. According to the latest World Malaria Report, dated 30 November 2020, we see the following global statistics. There were an estimated 229 million cases of malaria in 2019, compared to 228 million cases in 2018. The estimated number of malaria deaths was 409,000 in 2019 versus 411,000 in 2018. The WHO African region continues to carry a disproportionately high share of the global malaria burden. In 2019, the region was home to 94% of all malaria cases and deaths. In 2019, 6 countries accounted for approximately half of all malaria deaths worldwide: Nigeria at 23%, the Democratic Republic of the Congo at 11%, United Republic of Tanzania at 5%, Burkina Faso at 4%, Mozambique at 4%, and Niger at 4% each. The WHO regions of Southeast Asia, Eastern Mediterranean, Western Pacific, and the Americas are also at risk. Children under 5 years of age are the most vulnerable group affected by malaria. In 2019, they accounted for 67%, 274,000 of all malaria deaths worldwide. The WHO World Malaria Report 2020 indicates that India continues to make impressive gains in the reduction of its malaria burden. India is the only high endemic country which has reported a decline of 17.6% in 2019 over 2018. India has sustained an annual parasitic incidence, or API, of less than 1 since 2012. India has contributed to the largest drop in cases region-wide, from approximately 20 million to about 6 million. The percentage drop in malaria cases was 71.8%, and deaths was 73.9% between 2000 to 2019. Regarding India's Millennium Development Goal achievement, India achieved a reduction of 83.34% in malaria morbidity and 92% in malaria mortality between the year 2000, with 2,031,790 cases and 932 deaths, and 2019, with 338,494 cases and 77 deaths. This achieved Goal 6 of the Millennium Development Goals, which targeted a 50 to 75% decrease in case incidence between 2000 and 2019. This is the malaria map of India, showing the stratification of annual parasite incidence as per district for the year 2016. This map shows the stratification of API as per District of India for the year 2018. This map shows the stratification of API as per District of India for the year 2019. Section 2, Economic Impact of Malaria. Malaria can strain national economies, impacting some nations' gross domestic product by as much as an estimated 5 to 6%. It is estimated that the total economic burden from malaria in India could be around $1,940 million or 14,552 crore rupees. The major burden comes from loss of earnings at 75%, and 24% comes from treatment costs. Malaria discourages investments and tourism, affects land use patterns and crop selection, reduces labor productivity, and impairs learning. Malaria, poverty. Malaria, the socio-economic cycle is inherent. Section 3, Odisha, a success story. Odisha, an example of success against malaria. This chart shows the trend of malaria in the state of Odisha. There were 4.4 lakh malaria-positive cases in 2016, which has been reduced to 0.2 lakh in 2020, which showed a 94.6% reduction in malaria cases in the state. Major interventions in Odisha include long-lasting insecticidal nets. 11.7 million LLINs were distributed in 2017. Replenishment and additional coverage accounted for 15.3 million in 2020-2021. Durgama Anshalare malaria near Curran.
4.57 million mass screenings and point-of-care treatments were provided in hard-to-reach villages and hamlets. Supportive interventions: over 48,000 ASHAs, 1,200 volunteers, and 1,200 other health workers were trained to provide community and primary care services. Section 4. Strategy and Epidemiological Determinants. In May 2015, the World Health Assembly endorsed the Global Technical Strategy for Malaria 2016-2030, a technical framework for all malaria endemic countries. The strategy sets ambitious but achievable global targets, including eliminating malaria from at least 35 countries and reducing malaria case incidence and mortality rates by at least 90% by 2030.
Regarding the elimination strategy, taking the clues from the Global Technical Strategy for Malaria Elimination 2016 to 2030, SC Block district-specific strategies are to be built up. The village, being the unit of malaria elimination, will have to achieve an API of less than 1 and sustain the same for more than 3 consecutive years.
Key definitions include API, or annual parasite incidence, is the number of malaria-positive cases per 1,000 population per annum. ABR, or annual blood examination rate, is the number of blood samples examined per 100 population in a year. An ABR of 10 and above is taken for good malaria surveillance.
This is the malaria epidemiological triad, illustrating the relationship between agent, host, and environment. The 4 local determinants are agent, host, vector, and environmental factors.
Climatic factors. Both vectors and plasmodia are influenced by climatic factors: temperature, rainfall, and relative humidity. Temperature affects the life cycle of plasmodia. The time for parasite development in the mosquito is about 10 days, but varies with temperature. P. vivax and P. falciparum have the shortest development cycles. For mosquito vectors, the minimum temperature is 8-10 degrees Celsius, optimum is 25-27 degrees Celsius, and maximum is 40 degrees Celsius.
Section 5. Shifting Transmission and Challenges.
Regarding the shift in malaria seasonality based on the state's average, there is an early start of the transmission season now as compared to the past. The peak transmission is now in the month of May and June. It is a big challenge to program managers to cope up with the new seasonality. Pre-transmission indoor residual spray operation needs to be completed before the transmission starts. The pre-transmission period is now the hottest season with high humidity, so community compliance for IRS and use of bed nets during this period is a challenge.
Challenges in malaria elimination. Malaria is increasingly imported. It is caused by Plasmodium vivax in settings outside sub-Saharan Africa. It is clustered in small geographical areas or demographically into subpopulations, often predominantly adult men. Traditional control interventions are likely to be less effective. Approaches to elimination need to be aligned with these changes through the development and adoption of novel strategies and methods.
Section 6. Vulnerable populations and factors. Higher risk populations include under 5 children, pregnant women, patients with HIV/AIDS, and non-immune migrants.
Determinants among children include malnutrition, anemia, education of household head, residence type, and housing pattern. A pregnant mother's body is compromised and most vulnerable for PFA infection due to low immunity. Additional vulnerable groups. In districts like Koraput, tribal and marginalized communities reside in Kordia. These are small huts situated 3-4 kilometers away from the main villages. Population in border areas of administrative units. Population in small hamlets in a remote area.
Influencing factors of malaria transmission include human factors: age, sex, immunity, morbidities, education, habitation site, poverty, livelihood, migration, housing pattern, personal protection measures, etc. Other factors: climatic changes, developmental projects, displacement, disasters, resistance of anti-malaria medicines, insecticides, low-reach public health facilities. Findings from a SAMS study: malaria occurrence was higher among participants who had lower incomes, lived in bamboo houses, and were located at a considerable distance from a health subcenter. Knowledge and awareness about malaria, number of mosquito bites per day, and use of bed nets were also associated with malaria occurrence. Variables related to poverty, poor health infrastructure, and awareness about malaria are the most important factors in minimizing the risk of malaria.
Malaria program targets are achieving intensive control measures in high endemic areas, ensuring zero indigenous malaria in low endemic areas, sustaining zero malaria transmission status, and preventing reestablishment of infection or transmission.